The broadcast is now starting. All attendees are in listen-only mode.
That was Phil Collins, one of the all-time rock and roll great classic superstars. We're going to have more of him today and probably a couple of other really great old rock guys too. Today is Thursday, It's the 27th of January, 2022. It's 9 o'clock in the morning exactly here in the Chicago area, Zion. But the important thing is, Zion is no longer 1 degree below zero like it was in our last webinar a couple of days ago. We are now 25 whole degrees Fahrenheit above zero. That makes us practically tropical. Nevertheless, I'm still wearing a nice warm little fiery color sweatshirt here. And let's talk about what we're going to talk about. What we're going to talk about today is exclusively breast diseases. And of course, as you might guess, it would be 99% female breast and maybe 1% male breast. And that's going to be one of our last webinars in this huge, long series of genitourinary. We might have a lab or two after this. But the thing I want to tell you is that when I was looking through the PowerPoints today, I noticed we had an increasing large number. So you think, oh my God, this is going to last for 20 hours. No, actually, it's going to be probably my most pictorial or graphic. And I don't mean graphic in the shocking sense of the word. I mean it. Almost everything we show today is going to be pictures, and we'll be talking about it. Very few, as you saw, probably, PowerPoints that have a bunch of bullet points on them. So it won't take that long, even though we have like 70-something PowerPoints. Usually I do like about 50. Today is 70, but we're going to go through it pretty quick. I guess it's time to close that ugly guy and open up the beautiful PowerPoints. So let's get going. Let's go, Brandon. So here we go. Breast. Probably not the way you've seen it before in anatomy or histology or some of your little porn literature that you might have. But basically, this is a very good thing because it shows all the features. It shows the ribs. It shows the pectoralis muscle, the skin, the nipple, the areola, the lobes, the fat. Okay? And basically, anatomically speaking, the breast lies on top of the pectoralis major, and it gets supplied usually by two main arterial groups. Okay, medially coming off of the subclavian is the internal thoracic. The old name for the internal thoracic was the internal mammary, so I think you probably know why. And then laterally, another branch off of the subclavian is the axillary artery supplying it laterally. Okay, so this is a very, very good thing. You could see its relationship to the ribs too. Approximately from the 1st to the 6th is where most of the breast tissue is. In terms of lymph nodes, because that's probably one of the most important things, is most of the breast is drained into the so-called axillary lymph nodes, which are in proximity of the axillary artery. However, sometimes, occasionally, you might see a lymph node from a breast tumor appear above the rib or the clavicle, so to speak, in the supraclavicular area. That can drain the breast as well. And of course, the internal mammary or internal thoracic artery, like all major arteries, has groups of lymph nodes alongside of it. So you can also drain the breast from the lymphatic wise, whether it's inflammation or tumor, medially towards the internal mammary lymph nodes. But I'd say approximately, 95% of the lymphatic drainage is axillary. And so much attention is given to that, especially by the surgeons and the pathologists. So, in the histology of the breast now, you might not have known this, but the breast actually has lobes. You probably never appreciated that from anatomy, but there's about 10 approximately. And then there's many, many, many lobules per lobe. Okay, now in a lobule, you have many, many, many alveoli or acini, whatever you want to call them. And acinus is the singular of acini, and alveolus is the singular of alveoli. There's many of those. So now you're actually at the functional level of the acini. The acini themselves have epithelial cells and cells surrounding them, slightly contractile. That's why they're called myoepithelial cells as well. But it's only the epithelial cells that make the secretion, okay? The myoepithelial cells supply the motility. The ducts can be within the lobule or within the lobe, or actually outside of it, okay? And of course, the larger the duct, the larger the thing it might have drained from, like for a lobe. Now, a lot of people will say, where is this suspensory ligament I hear about? Well, it's not like any other ligament you'll ever find in your body, because it's not really a solid piece of fibrous connective tissue like most ligaments are. It's actually a network of thick fibrous bands that hold the lobes together. So if you were to dissect this breast, you'd see there's a nice band of connective tissue separating this lobe from other lobes, and that's the so-called suspensory ligament. Otherwise, even at the lobular level, there's small, much smaller bands of fibrous tissue which are not technically part of the suspensory ligament. Well, here it is. We saw the lobe. We now see the lobule. This is probably part of a lobe, and I'm thinking that's because you see a very thick band of fibrous tissue. So this whole thing here might be part of a lobe, but the lobules are separated from the rest of the lobules within the lobe by smaller bands of connective tissue. Okay, they're pretty easy to point out. And of course, those tiny little clusters of cells, looks like most of them have somewhat of a lumen, are the actual acini or alveoli. Okay, and here it is in a nice H&E preparation. But here it is in this scanning electron microscope picture. So this is an entire acinus over here. And these are individual epithelial cells, the functional cells of the breast in the functional unit called the acinus. And then between the cells you have the cytoplasmic, somewhat contractile cells of the myoepithelial cells, which the nuclei are a little smaller. And of course they're not part of the secretory function at all. And the acinus now, we've gone from breast to lobe to lobule to alveolus or acinus, all the way to the epithelial cells and myoepithelial cells. And you don't get much more detailed than that. There's three normal phases to the breast, and we're going to exclude the embryologic phase, okay? The average premenopausal woman is something you would probably say had an active phase. In other words, no matter how you slice the breast in a slide, you're going to see about 50% glands or blue clusters and about 50% bands of fibrous tissue or pink bands, okay? So, you know, I don't know if this is actually part of any anatomy book. It's just mostly my experience for looking at millions of these things. Let's just say it's about a 50-50 ratio of glands to stroma, or glands to connective tissue. Of course, when that breast becomes pregnant and then lactating, we now go from a 50-50 to a breast that is predominantly secretory, and it's much greater than 50-50. Maybe it's 90 glands and much less stroma in between. And of course, atrophy, part of the normal lifespan of a breast or a woman, usually starting to occur, you know, after menopause. Now you have more of a predominance of fibrous tissue over glandular tissue. And of course, most of the breasts you will examine, because of the fact that breast carcinoma occurs in a, you know, usually women over 50, generally speaking, with a lot of exceptions, are going to be seeing biopsies in which there's more connective tissue than glands. Now, what would you say about this breast over here? Well, you could say you could see a lobule, you could see another lobule, you could see a third, a fourth, maybe a fifth lobule, you could see a duct, interlobular, and then there are some ducts, of course, within the lobule as well. Just like you could have ducts within a lobe or ducts between the lobes, okay? Same type of analogy. This is probably one of the nicest biopsies of an active breast, but not lactating or not atrophic. Why? Because I think if you took your mind and you looked at this picture and you'd say, well, it looks like about half of the cross-sectional area is blue and maybe about half of it is pink. Generally speaking, 50-50. So this is a normal, active, premenopausal woman's breast. Now let's say we're going to call this a quiz or not. We don't have to call it a quiz. I'll tell you the answer. Here we have a lobule, maybe more than one. But look at, it's almost all glands and even secretions within the glands. So it's a much greater than a 50% ratio here. And could you say this was a woman who was pregnant? Could you say maybe this could be a woman that was even lactating? I don't think you could easily tell the difference. Here we are, here in the northeast corner, looking at this small cuts, but the entire lobe or perhaps portion of breast is more than 50% blue and less than 50% pink. Okay, what about this breast biopsy? Is it mostly pink? Is it mostly fibrous tissue? Does it have a relative lack of glandular cells within the lobules? Yeah, so this could be a woman that's perfectly normal, perfectly healthy, normal breast, but it just happens to be probably post-menopausal, okay? Here's a nice blood vessel. Oh, this is kind of a big duct. Could that be perhaps a interlobular or maybe even part of an interlobar duct? Certainly it could be. But once again, I think even by now, even if you've never seen much breast before, you can pretty much identify this little structure like we see here as a lobule, just like we saw. These were 4 or 5 lobules, and that was a lobule, okay? So just to get that feeling again. Now, this is going to be the quiz now coming up, okay? You don't have to answer because most of the times you don't anyway. But here we have a breast, and you're probably thinking, oh my God, come on, don't fool us. We know this isn't a breast. This is a thyroid gland. Well, this is a breast that is probably lactating, okay? And look, in most of the lobules, the predominant feature is not blue acini or blue lobules or pink fibrous tissue. It's actually secreted material, milk within the acini, milk in the interlobular ducts, and you could probably guess that even the big interlobar ducts are probably filled with the tubes. This could very easily be a lactating breast. And I want to tell you something. I think I'll show you another picture of something like this, but you know, there's only 3 things in the world that I could think of that could be confused with the thyroid gland. And this is one of them. If you blew this thing up, you might say, hey, maybe that's a thyroid. Another thing is a so-called thyroidization of the kidney, which we saw in the earlier part of this block when we talked about chronic pyelonephritis. And the other thing was the intermediate lobe of the pituitary has these thyroid-like follicles. Or I guess if I thought real hard, if I felt real smart one day, I could say, well, is there anything else? Well, don't forget, teratomas, benign or malignant, but mostly benign, can have thyroid tissue as well. So it's not unusual for a woman to have a tumor in the ovary that has thyroid tissue in it, and it takes up radioactive iodine. Not only does it look like thyroid, but it functions like thyroid. So here we go. I wrote this down not because it's profound or not because it's from a book, but the most important thing in breast pathology is just to understand. I should probably put the word, get the feel for the breast lobule, okay? Get a feel for an acinus. Get a feel for the stroma or the connective tissue between the lobule, okay, and the boundaries. Also, it's not very likely in the average breast biopsy you'll see an entire lobe, because remember, there's only 10 lobes about. You know, if somebody said, well, you know, some book told me it was 8 or 12, I'm not going to argue with you. But once again, I'm going to go back to that slide, okay? What I want you to do is just look at this. and blink your eyes like your eyes were your iPhone and just take a picture, because that's about the most normal looking lobule part of the lobe and stroma that you'll ever see. Now, where was I? Yeah, what we were is over here. Now we're going to talk about breast diseases, okay? And like almost every organ or system we talked about, we started out with congenital or developmental disorders, congenital disorders, or we call developmental diseases. Breast has some of those. We'll talk about the degenerative diseases. We've already talked about the degenerative diseases. We told you that every woman's breast will degenerate. The lobules will get, the breast will get probably smaller, unless, of course, the fat makes up for it with age, which it usually does. And also the fact that atrophic or lobules, which are not quite as cellular, is common. In fact, the general rule, after menopause. Could you have inflammatory diseases of the breast? Of course you can. If you remember, embryologically, the breast has always been described as a modified sweat gland. So can sweat glands become inflamed with the superficial soft tissue bacteria, or perhaps even other few exotic things? Of course. And could the inflammation be in the duct? Could it be around the duct? Could it be acute? Could it be chronic? Yeah, all the usual things. Nothing special here. But the special thing, and the thing we'll be spending most of our time on, is the number one cancer, not the number one killer, but the number one cancer of women, breast carcinoma. So we'll talk about benign neoplasms. We'll be talking about malignant neoplasms. We'll be talking about neoplasms of the connective tissue. We'll be talking about neoplasms of the epithelium. And if you wanted to generally say that just about all of the carcinomas of the breast are adenocarcinomas, you're probably right, because the breast is a gland. That's why. Could you have a squamous carcinoma of the breast? Yeah, you can, but there is no squamous tissue primarily inherent in the breast. So if you have a breast carcinoma that is squamous, which is rare, it's probably going to be from squamous metaplasia of the ducts. And if you remember, we said it 3 or 4 times already, squamous metaplasia of the duct of any gland is usually secondary to some type of inflammatory process. So let's start out with the developmental, which is right here. Milk line remnants, what are those? We're going to find out, because we show you a beautiful picture. Could you have an accessory breast tissue? In other words, a breast but kind of a prominent lobe, which is maybe connected to the main breast, or maybe even separate? Of course you can. That could occur in embryogenesis as well. Can you have an inversion of the nipple? Yes, you can. You could be born with it, as a matter of fact. Or if it occurs after you're born, perhaps it's secondary to an inflammatory process. But a nipple retraction or nipple inversion by itself in a woman has to be regarded as suspicious for perhaps an underlying neoplasm that has caused fibrosis, like a fibrosing or serous carcinoma of the breast, which can contract the nipple and the fibrous tissue associated with it. Can you have large breasts? Oh yeah, sure you can. Could you just be born with it? Could it be secondary to estrogens? Could it be secondary to obesity? Yeah, it even could be secondary to a few other things. But let's talk about the so-called milk line remnants first. Well, here's a woman with a breast, 2 nice breasts. And you can see somebody drew a line from the axilla and even into the proximal arm, going all the way down to the inguinal region, okay, and even past it, okay. This is what they call a milk line. And in embryogenesis, the part of the milk line that actually develops finally into the breast is right up here. But could there be errors of embryogenesis where you have nipples or even breast tissue along this milk line? Yes, you can. And most of the accessory nipples along the milk line or even accessory breast tissue might not even look like a breast. They might look like a little nevus, or what the woman might call a mole. Here, I'm going to show you a really good example. For those of you that are girls or even boys, because this is a boy, go home tonight, or hey, take off your shirt now if you want to, because you're going to look at two nipples, aren't you? But draw that imaginary milk line again, going from the axilla down to the inguinal region. Do you have any moles, or what you might call a nevus, or pigmented areas within that so-called imaginary milk line? If you do, they could very easily be accessory nipples. They're not going to have necessarily ducts, but they could. And they could even have some accessory tissue, but mostly it's just what you might call an accessory nipple along the milk line, or an accessory nipple remnant. It certainly is not functional, usually. Okay. Women. Oh, I'm not going to say men. Do you have a little bit of extra fat in your armpit, an axillary swelling that maybe you've had, and perhaps it even has gotten bigger when your breasts got bigger? Okay, this could be accessory, which is usually axillary breast tissue. Remember, this is also in the milk line, isn't it? That's not uncommon either. It might be thought of as just being a little bit of extra fat, but what if it wasn't on the other side? Or what if the breasts were not big or fat? This is a good area to consider if you have that little extra soft swelling in your axilla as possibly accessory or axillary breast tissue. Okay, so far so good. We're not worried about anything. We're not worried about accessory nipples or a little bit of accessory breast tissue. However, what happens if your nipple is inverted, or what they call retracted? Okay, this is not like a fully round, puffy nipple. It's kind of indented up here superiorly. Maybe she was born that way. If she was born that way, and she gets to be 50 years old, you can say, well, I've always had it. You know, some people might have a little lump on their neck like I do. And every time I go to a doctor, he's worried about it being something. I say, well, I had it since I was a teenager, and I'm 74 now. So do you think it's cancer? Okay. No, it's probably just a lipoma. Well, you could be born with it. It may persist your entire life. Now, maybe this woman had her nipples pierced, because I noticed now more and more women are doing it. I don't know why tattoos and piercing seem to be, pandemic these days. So maybe it's just a little scar from her nipple being pierced. So if she presents this way and she goes, oh yeah, a few years ago I had a nipple ring, and maybe that's the scar from it. But the important thing to remember, can I write on this or not? Yeah. The important thing to remember, let me make this a different color, is if a woman presents with an inverted nipple and she wasn't born with it and she never had her nipples pierced, it doesn't matter what age she is, that could be an underlying cancer causing scar and contraction in that area. Okay, so that's the thing that has to be mammogrammed and examined, and if you miss it, you may be sued, or even worse, you may kill the patient. Okay, so an acquired adult nipple retraction with no history of piercing and never had it earlier has to be regarded as suspect, because most of the breast carcinomas evoke a tremendous amount of fibrosis, and that's why they're called serous carcinomas, just like cirrhosis is called cirrhosis because that means scar, because in cirrhosis the liver is scarred. Also, in most breast carcinomas, most infiltrating breast carcinomas, there's a lot of scarring that could go on and cause this type of thing. Oh, I think we all know what this is. It's called macromastia. It just means big boobs. Why does she have big boobs? Well, maybe she just always had big boobs. Could she just be obese? Yeah, that's a possibility. Could she be pregnant? Well, you know, big breasts could even get much bigger in pregnancy because of the estrogen effect. You know, even I think even birth control pills, I was told can do this. I didn't know that until recently, but let me look that up now. 384. Here we go. Yeah, birth control pills could do it. Okay, or she could just happen to be a fat, or she could just happen to be a woman with big breasts. Okay, they're not red, they're not swollen, they're not painful, they're probably not inflamed. And what about the degenerative diseases? Well, I don't know if I would call it a disease. We usually talk about degenerative diseases of any system, but atrophy of the breast occurs normally starting after menopause. We're talking about atrophy of the glandular elements, you know, the secretory lobules and lobes and acini generally get smaller and more fibrotic. But don't forget, this is also a time of life where fat can come in. So even though a woman could be elderly, you might say, well, you know, her breasts didn't get smaller, they actually got bigger. That's probably mostly fat. So just like we talked about a fibrous tissue glandular ratio, the ratio between glandular tissue and fat also gets significantly lower, okay, with age as well. What about the inflammatory diseases? There's no surprise here. Breast is a modified sweat gland. Sweat glands are in the skin. The most common infectious agents of skin causing cellulitis are staph and strep. So an acute inflammation with staph would probably be the most likely thing. Could you have inflammation around the duct? Very often, much of the inflammation in the breast tissue is periductal. But you can also have obstruction of the duct, which causes not only inflammation in the duct, acute or chronically. Could the obstruction be from a blood clot? Could it be from fibrosis? Could it be from blockage of the normal secretion pathways? Yes. And when you have blockage or obstruction of any tubular structure in the body, not just breast, not just glands, you can get dilatation of the duct proximal to the obstruction. Fat necrosis is a type of inflammation. The etiology of fat necrosis is usually a traumatic insult to the breast. Could it be trauma? Yes, but most likely it's been due to previous surgery where there normally would be a lot of trauma, okay? Would you call a lymphocytic inflammation the same as a chronic inflammation? Just like we said acute was neutrophils, chronic is basically lymphocytes. Yes, you can. Diabetics characteristically often have mastitis, inflammation in the breast that is primarily lymphocytic or chronic. So if you called diabetic lymphocytic inflammation the same as chronic mastitis, you basically would be correct. Now don't forget, there's granulomatous inflammation as well. Could sarcoid involve the breast, which is a granulomatous disease? Yes. Could tuberculosis involve the breast, which is granulomatous? Yes. Could fungi, could foreign bodies? Yes, yes, yes. However, most of the granulomatous inflammation of the breast is idiopathic. We don't know what causes it. Oh, there's been reports of it being linked to birth control pills and a couple of other things, but like everything else, when you see a granulomatous pattern of inflammation, you say the same thing that Hamlet said, TB or not TB. Here's an acute mastitis. We could see a duct. We could see fibrous tissue between the duct. You can see neutrophils within the duct, okay? And this is called acute inflammation pathologically because of the presence of neutrophils. But acute inflammation clinically would mean the breast is red, the breast is swollen, the breast is painful, okay? Heat, the breast is hot. So those are the 4 classical signs of acute inflammation: heat, swelling, pain, and redness. And of course, if you remember when we talked about acute inflammation, we said sometimes somebody decides to add a 5th thing, which is called functio laesa, like the 5th Marx brother. Okay, and that just means loss of function. So a breast that is inflamed will not function whichever the way the breast has to function. If you did just a regular smear pap stain or cytologic prep, maybe an easy type stain, you would say that in this acute mastitis here, or these neutrophils filling the ducts here, if they wound up getting expressed through the nipple, what would you see? Well, I think you'll agree that almost probably 90-80% of these cells are neutrophils, acute mastitis. Do you see malignant looking cells? Well, you have to examine it very carefully, but not offhand. But I wanted to remind you that many of the carcinomas of the breast do not have terribly malignant looking cells. That makes it kind of scary, doesn't it? Especially for a cytologist. Here's a breast that's red and swollen and painful and tender. You say, well, this got to be mastitis. Well, it is a mastitis, so to speak, but it's a type of cancer called inflammatory carcinoma because it looks like it's inflamed. And why would a cancer present as a diffusely inflamed breast? Well, if you get a close look at the skin here, you can see there's kind of an exaggeration of the dimpling, okay, of these sweat gland ducts. In fact, here, would you say it looks a lot like an orange peel? Well, the French have a word for this inflammatory carcinoma of the breast. They call it peau d'orange, because that, in French, you would guess that might mean peel of orange or orange peel. So when you have a breast that's diffusely inflamed and have a prominence of this, you might think it is cancer. And I got news for you. Not many people survive this, okay? This is inflamed because the little tumor nests are diffusely infiltrating or involving the dermal lymphatics. And because of that, there is an increased amount of edema in the dermis, and the increased amount of edema is making these little puckered spots look more prominent. So that's a type of inflammation that really is a cancer, but it's still called inflammatory carcinoma. Here's a breast biopsy, and I think you could say, well, you could see ducts, you could see a lot of fibrous tissue, you can see epithelial cells within the ducts, but you can see a lot of chronic inflammatory cells. You know they're lymphocytes, right? Because they have a very little cytoplasm. That's why they look blue. You can see fat here on the left. You can see a little bit of fat in the northeast. And you see fibrous tissue between these ducts. So just simply, this could be called, honestly, periductal inflammation. And it's very, very, very common. Now, could you also have inflammation within the duct? Of course you can. In fact, that's exactly what we saw here, isn't it? But this is periductal inflammation. It might cause the duct to become fibrotic or compressed, and it could cause some of these ducts to be dilated and be cystic. And what if they were cystic and these little things were little cysts? And what if this amount of fibrous tissue followed the chronic inflammation, like scarring awfully does? Then you might call this fibrocystic disease. And I'm sure you've heard that word before, because fibrocystic disease is the most common word and maybe the most common diagnosis that's used to describe a benign breast lesion that is not cancer. But there's a gray zone, and we're going to talk about that. Here's some ducts and some fibrosis surrounding them. And can I ask you, this may have been part of a lobule at one time, or maybe this, but let's say that this had been inflamed, or there is fibrosis in this breast. It's probably a woman that is not young, because we don't have very much by way of acini here, or lobulation even. The more fibrosis around the ducts, the more it might cause these ducts to become dilated, because parts of them are simply compressed by the fibrous tissue. The word for this is ductasia. Okay? Do you want to call it a cyst or a microcyst? Sure, you can. You want to call it a dilated duct? Sure, you can. But the word is ductasia that you'll see on the pathology reports. Now, here's a breast biopsy grossly, in which you could see that we have actual cysts here. Maybe they're black because they're even filled with blood. Here's another one, okay? So the point I'm trying to make is that ductasia, if it gets not treated, or its normal progression, the ducts might become so dilated that they actually become cysts. And that cyst can be palpated. It might be worrisome. It could generally be seen pretty nicely as a cyst rather than a solid substance on mammography. But these are cysts. Maybe you want to call it fibrocystic disease? Sure. You want to call it fibrocystic disease secondary to dilated ducts and fibrosis? Sure, that's where the name comes from. But you can't call it cancer unless you see cancer, and we haven't seen that yet. Now, here's some more breast tissue, and here's some fat, as you can see, in the southeast. And here's even a bigger cystic type structure here. And look, these cysts are lined by sort of a cuboidal blue epithelium. But now some of these cysts, smaller cysts, have more of a columnar red epithelium. So what is that called? When the cells in cysts still look benign, but they become taller and redder. That's called apocrine metaplasia, because if you examine apocrine glands, where they normally are in the body, like the axilla or the inguinal region, they have this kind of epithelium. So the correct term for this situation is apocrine metaplasia. Remember, metaplasia is a benign process where the taller, redder glandular cells are seen in contrast with the normal lining of the ducts, which are more cuboidal and more blue. What's this over here? Well, it's another type of breast lesion that could even be palpated as perhaps lumpy or a mass or be worrisome. It's called fat necrosis. And what is fat necrosis? Well, that's exactly what it is. It's necrosis of the fat. Remember, breast, especially in elderly women, can be mostly fat. Okay, well, if that fat has been traumatized, two things could happen. One of them is that the hemorrhage from the trauma can be picked up by these macrophages. You see that pigment there, and you see that pigment there, and you see that pigment there. And also, the debris can then be swallowed up by macrophages, and sometimes the macrophages look upon the debris as either being foreign material, or perhaps they need to coalesce their cytoplasm in order to digest it more popular. So there's a multinucleated macrophage. There's a multinucleated macrophage. There's one. There's one. So the features of fat necrosis are hemosiderin macrophages, multinucleated macrophages, which are called giant cells because they're multinucleated. But the third thing is that if this goes on, it can become fibrotic as well, not just looking like necrotic fat. And it could be palpated as something firmer than the rest of the breast tissue. Okay, there's the fat necrosis. What is this? Well, it's nothing exciting. I think you might have to have some experience to believe and recognize that even though some of these big cells here look bluer and maybe you're worried already, they're basically still following a pretty well-defined lobular pattern. But also, I think I convince you easily now that these little cells, which have round central nuclei and minimal cytoplasm are all lymphocytes. So you want to call this a lymphocytic mastitis? Sure, because that's exactly what it is. Do you want to call it a chronic mastitis? Because lymphocytes are pathologically the hallmark cells of chronic inflammation? Sure, you can do that too. Hold on, I got this phone that is bugging the hell out of me. So I'm going to have to turn it down. And I'll deal with those idiots later. And I think I turned it down. Yeah, we turned it down. Lymphocytic or chronic mastitis occurs often with diabetic patients. Not extremely often, but if you have a patient that have been diagnosed as lymphocytic mastitis, first of all, the pathologist may have either called it chronic mastitis or ignored it completely, but it could present with clinical symptoms as well. The patient may very well be diabetic. And finally, the last type of inflammation is what we call granulomatous inflammation. Okay, well, what are these cells surrounded by some breast lobules? They're mostly macrophages, or what the pathologist would call histiocytes. Some of these histiocytes have multiple nuclei in them. There's a multinucleated giant cell. There's a multinucleated giant cell. That one definitely is. So it's a granuloma. And of course, in the classical granulomas, you often have a little rim of lymphocytes surrounding these macrophages. So once again, you got granulomatous inflammation in the breast. Could it be TB? Yeah. Could it be sarcoid? Yeah. If it was showed central necrosis or central caseation, would it be more likely tuberculosis than sarcoid? Yeah. Could it be possibly secondary to birth control pills? I didn't know this until yesterday, but BCPs have been linked to granulomatous mastitis. And also lactation. So as the breast lactates, perhaps more of this proteinaceous material can evoke kind of a granulomatous or foreign body type of reaction. So that's the differential diagnosis of granulomatous mastitis. If this woman had histoplasmosis or some other systemic fungal disease, could it be that as well? Yes, it could. Okay, we talked about everything except tumors. So we're going to take the second hour and talk about nothing but breast tumors, okay? So when we come back after our 10-minute break, we're going to get into the topic as the number one concern in women's cancer, and that's going to be neoplasia, benign and malignant, premalignant, borderline, intraductal, infiltrating, intralobular, infiltrating lobular, and technically even there are some diseases that could be neoplasms of the stroma or connective tissue rather than the more mitotically normally active glandular or epithelial tissue. So we're going to play, I don't know, maybe we have another Phil Collins coming up, but we're going to do 3 nice little classic rock and roll songs, and I think I'll just kind of chill out and recycle my coffee during the break as well. Here we go, folks.
let you leave without a trace. When I stand here taking every breath with you, ooh, you're the only one who really knew me at all. How can you just walk away from me when all I can do is watch you leave? 'Cause we shared the laughter and the pain, and even shared the tears. You're the only one who really knew me at all. So take a look at me now. There's just an empty space. There's nothing left here to remind me. Just a memory of your face. Oh, take a look at me now. There's just an empty space. And you coming back to me is against the odds. And that's what I've got to face. I wish I could just make you turn around and see me cry. There's so much I need to say to you, so many reasons why. You're the only one who really knew me at all. So take a look at me now. Well, there's just an empty space. There's nothing left here to remind me. Just a memory of your face. Now take a look at me now. 'Cause there's just an empty space. But to wait for you is all I can do, and that's what I've gotta face. Take a good look at me now. 'Cause I'm still standing here, and you coming back to me is against all odds. It's the chance I've gotta take. Take a look at me now. One more night, one more night. I've been trying for so long to let you know how I feel. And if I stumble, if I fall, just help me back so I can make you see. Please give me one more night. Give me one more night. One more night. 'Cause I can't live forever. Give me just one more night. Ooh, just one more night. Oh, one more night. 'Cause I can't live forever. I've been sitting here so long, wasting time, just staring at the phone. And I was wondering, should I call you? Then I thought, maybe you're not alone. Please give me one more night. Give me just one more night. Oh, one the same. And I know it's only words, but if you change your mind, you know that I'll be here, and maybe we both can learn. Give me just one more night, give me just one more night, one more night, 'cause I can't wait forever. Give me just one more night, give me just one more night, one more night, 'cause I can't wait forever.
Well, it looks like all of our music was from Phil Collins and Genesis today. And I even heard the beginning of the last song we'll play. And actually, that's my favorite Phil Collins song. Don't ask me why, but I just love it. It's called In the Air. Okay, let's, usually I have some type of thought that I have during the break and I tell you about it, but not today. The only thing that's really been on my mind now, the last several webinars, is like the weather. Like I'm just so happy that it's 25 degrees above 0 Fahrenheit now. The last one, I thought I was going to die, I still have the space heater on anyway. I hope it hasn't interfered with my lecture. And if any of you would like to comment, I would want to ask the question again. Does the noise from the space heater interfere with my lecture? Last time you guys said no, and I'm hoping that somebody can be brave enough to answer again today. Well, maybe nobody's brave, but I'm a lot braver now because it's a lot warmer. So let's close this guy off and talk about nothing but neoplasms of the breast. Here we go. Could you have a benign or malignant neoplasm? Yeah, that's how we've divided all of our discussions of cancers of different area. Could it be a neoplasm of the epithelium? Yeah. Could it be a benign neoplasm of mostly the stroma or connective tissue? Yeah. Could it be premalignant or what we call worrisome or dysplastic? Yeah. There's a lot of features that would indicate that. Could it be a malignancy of the epithelium, whether it was the epithelium of the duct or the epithelium of the lobules? Yes. Could it be inside the duct or in situ? Or could it be completely inside the acini of the lobules? Yes, it could be either intraductal or intralobular. Could it be infiltrating ductal or could it be infiltrating lobular? Yeah. Well, if it was intraductal or intralobular, it would be carcinoma in situ, wouldn't it? But if it breaks through that basement membrane of the duct or the lobule, then it's infiltrating. Now, up until now, we've been talking pretty much only about neoplasms of the glands, because the glands of the breast are the things that normally turn over and have the most susceptibility to a wide variety of cancers and causes. But could you have a malignant proliferation of just the connective tissue? Yeah, that's possible. It's very, very rare, and very often when you do see it, it's probably in combination with the epithelium as well. So why do women go to doctors when they worry about their breasts? Well, maybe they palpated something, or maybe they had a routine mammogram and they found something worrisome, or something that should be evaluated more. Maybe they had a nipple discharge. Well, could that be inflammation? Of course. But it can also be discharge from a tumor that's inside the duct or involves the duct. What about a nipple retraction? Maybe that's the reason. What about pain? Maybe that's the reason. But remember, pain is also a main qualifying factor for the mastitis as well. So there's a wide variety of reasons. Now, once again, you can say there got to be 3 types of benign lesions of the breast. And these are all generally called fibrocystic disease. Even if there's not a lot of fibrosis, or even if there's not gross or microscopic cysts, the benign epithelial lesions of the breast are just all kind of lumped together generically and often called fibrocystic disease. And usually there's some element of fibrosis, and usually there's some element of duct dilatation or cysts. Now, it could be totally benign, in which the epithelium does not proliferate. Maybe it's just a cyst, or maybe it's just fibrosis, or maybe it's just some increased amount of cells within the lobule, which we define as adenosis. Could it be benign, but there is kind of a benign appearing increased growth of epithelium, like hyperplasia within the duct, okay? Or not only adenosis, but maybe some fibrotic reaction to it. So think about it. If you have a fibrotic reaction to normal, increased normal cells, that could often be scary and look like cancer, couldn't it? Could it be increased cells because the cells in the ducts are growing in an increased fashion to form papilla? Just like we saw with the prostate. We said in PIN, or pre-prostate malignancies, you can see the increased epithelium growing on little stalks or papillae. Or could you have an increase in growth of not only the epithelium, but particularly the connective tissue that supports it? We call it a fibroadenoma. It's the benign growth of both the fibrous tissue as well as the glandular tissue. Now, there is this little worrisome or third part of benign, which still may be called technically benign, but it's called atypical. In other words, it's proliferation, but in an atypical way. And those are the things that are the most worrisome, because these are the things which statistically have the most chance of becoming cancer. These don't at all, and these rarely do, but atypical epithelial proliferation as part of overall fibrocystic disease is worrisome, and will either require perhaps surgical biopsy or a lot of follow-up mammographies, or both. Well, this is the most simple type of benign breast tumor. Maybe it was palpated as a lump. You can see it's about 2 centimeters in diameter. The more superficial it was, the more likely it was to be palpated. It was a regular benign cyst. If you look at it microscopically, it may be filled with fluid or maybe a little bit of blood, and it'll have a nice even lining. The radiologist may see it as a area where there is lack of echoes, or what they might call hypoechoic, and instantly they'll know this is a cystic lesion, because that's just fluid inside there, and it's not tissue like you see in these more echoic things around it. Grossly, it looks like that. And this one looks like it's probably almost at least 1 centimeter too. But you have the duct, or the wall of the cyst, is basically a single lining of nice, orderly columnar cells They're not necrotic. They all are associated with fibrous tissue. They're never more than one cell layer thick. The nuclei don't look nasty. Here, I'll prove to you they don't look nasty. Let's take a look at that. The nuclei are normally at the base. Is there some fibrosis around it? Maybe. This is a benign cyst. If you want to call it a microscopic cyst, you can. But of course here, it might be in association with something that's at least 1 centimeter big. This is called adenosis. And adenosis is defined as increased acini within a lobule. Now remember all those pictures of lobules that we saw? But what if there was an increased number of cells like here within them rather than one nice little single layer? Now you got several. This is what you call adenosis, but it still has a normal overall lobular configuration, and this is benign. Sometimes this adenosis can evoke or be associated with a fibrotic reaction, and you might call it sclerosing adenosis. And the reason why sclerosing adenosis, it's benign, but the reason why it's scary is you have to have the experience and the knowledge and the support, and maybe you show the slide to your friends and to experts. They'll say, well, this fibrous tissue is just a reaction to these benign glands. It's not a case where the glands are invading into the fibrous tissue. But this is regular old adenosis. I'm going to show you sclerosing adenosis pretty soon. Here are some cysts. Look how nice and well delineated they are. Here's a lot of fibrosis around it. So what would you call a breast lesion that has a lot of fibrosis, which is the whole western half of this image, and a lot of the northeast as well, and all these little cysts. Classical fibrocystic disease, B9. Now, we also have fibrocystic disease in which the epithelium is increased, or you might call hyperplastic or proliferating, but it still ain't cancer. And we're going to see a few examples of that right now. Here you have a duct that's kind of normal, 1 or 2 layers. And now you have a duct in which there's multiple cells almost filling up the entire duct. Could you say those cells are hyperplastic? Yeah, you can. But they still look like normal cells. There's no necrosis, there's no infiltration. Ductal hyperplasia itself is benign. However, statistically only, not because of the way it looks, it is associated with more of a possible upcoming cancer than something that doesn't have ductal hyperplasia. That's why this is still regarded as benign. And you see these little cells here, kind of like at the base? These are myoepithelial cells. So if a duct is still mixed with this normal array of myoepithelial cells, like you see here, and probably here, and most likely here, it means it's benign. Now, you're ready for the scary one? Here's also some ducts, and there's hyperplastic at least, and it looks like there's increased cells. So you might call it adenosis. But look, do you see how surrounding this lobule, there's this kind of dense fibrous tissue? Well, the first thing that you're going to think of, even if you're an experienced pathologist, is this just fibrosis around or associated with adenosis? Or could this be infiltration of malignant cells into the overlying fibrous tissue? Well, that's why it's scary, and that's why it's a scary lesion. But because it has overall a nice still lobular configuration, most people will tell you that it's benign. And another nice feature is that if it's adenosis, whether it's sclerosing or not, you got these little cells at the periphery. Remember, in the acini you have epithelial cells and myoepithelial cells. So these myoepithelial cells still mean it's organized as an acinus, and it's sclerosing adenosis, even if it has a lot of fibrous tissue around it. but it ain't cancer. But it still might worry an average pathologist or even an experienced one. And usually in cases like this, we all have the names of guys that we know that are a lot smarter than we are and a lot more experienced. And there's even a separate specialty in pathology called breast pathology, which people can get certified in. And those might be the guys that you want to show the slide to if you want to make sure this is benign. Remember, if you call this benign and it's malignant, you possibly killed the patient. If you call it malignant, but it's really benign, maybe she lost a breast. So what's worse, losing your breast or losing your life? These are basically the decisions we have to deal with every day. Here's another sclerosing adenosis over here. But look, it's kind of arranged irregularly now, what they might call a complex sclerosing adenosis. Some people call this radial scar. These are the most scary of all lesions because you don't know if this is a area of infiltration because it doesn't conform to a lobule anymore. And these are the ones that basically scared the hell out of me when I was practicing pathology. And I would always send these to consultants. And actually, any good pathologist who doesn't send this lesion to a consultant is playing with fire. Not just the fire of a malpractice suit, but the fire of knowing that you've killed somebody, okay? Here's a little duct. And look, here are the epithelial cells that surround it. But some of these epithelial cells are proliferating like a tree. It's a little papilloma. It's not just epithelial cells, but there's a little bit of fibrous tissue between these little epithelial proliferations, the stalk. There's a papilloma. Papillomas are benign, okay? Here's a bigger papilloma, but do you see? Maybe it's in a bigger duct. Could this be palpated as a mass? Could this cause an obstruction? Could this cause infection? Could this cause a discharge? Yeah, it could, but it's still a benign papilloma. Here's even a bigger one. This one would be more worrisome, but it is still considered benign. But once again, it's proliferation of the epithelium and the connective tissue that puts it into a higher risk statistically of becoming cancer. And by the way, there's a rule. I don't know if I put it here. Yeah, there's a rule in pathology, and I'm talking mostly about pathology things today. I know several pathologists were my friends that got sued because they called this cancer and it wasn't. And the rule is this: if somebody gives this to you as a frozen section while the patient is still on the table and you call it cancer, they cut off her breast. Okay? When you look at the slide the next day more carefully, you realize it's just papillomas. And the malpractice attorney shows this to 20 other pathologists, and they all call it benign. So you're screwed. And in every case, the people I know who diagnosed papillary cancer on frozen section and were wrong, they all lost a lot of money. Okay, let's talk about the atypical epithelium now. We talked about normal, non-proliferative epithelium. We talked about proliferating epithelium, which was benign, but had an increased statistical risk of being associated with cancer somewhere down the line. And now we have something that's downright atypical, which means it's a much higher increased risk, even though you may not technically call it cancer. This is your atypical, so-called but benign glandular neoplasia. Okay, and here we go. Here are some features of the cells, mostly within the duct, that make the pathologist call it atypical, and some of them might just downright call it carcinoma in situ. The more stroma that you lose between the acini, the more worrisome it is. The more hyperplasia that you have, in which there's basically no stroma, it just looks like Swiss cheese, It's like glandular cells with holes in it, what they call Swiss cheese hyperplasia. That's a little worrisome too. Cribriforming is even more worrisome because it's like Swiss cheese hyperplasia, but more of the holes and less of the connective tissue. What if the cells were some large, some small, some dark, some little? In other words, the usual pleomorphism and hyperchromasia. Okay, what if you saw cells within a duct that had more mitoses than they should be? That's worrisome. Now, the two at the bottom I put is because these are the most worrisome of all. And usually, or often, they are just downright called intraductal carcinoma rather than normal or atypical. One of them is something called the Roman bridge, which I'm going to show you a picture of. And the other one is just necrotic cells. So just like we said that with prostate, the presence of nuclei is one of the most worrisome and almost downright positive examples of cancer. With ductal cells, necrosis is the most worrisome feature. In fact, some of these are called comedocarcinoma because the necrotic junk within the duct looks like a zit, okay, or a comedo, okay. And these ones with the 3 asterisks, if you see them on a pathology report, they will very, very often be talked about as part of intraductal or pre-infiltrating or non-infiltrating breast cancer. Here's a normal duct. Okay, here's a normal acinus. Okay, the myoepithelial smaller, thinner cells towards the periphery, and the actual glandular cells facing the lumen. Here's a regular duct. Okay, it's a little bit convoluted, but it's single layer. But here's a duct, what you might call Swiss cheese hyperplasia. Not only are they filling up the entire duct, but it doesn't look like there's much stroma or connective tissue between them. And in addition, I think I could convince you that some of these cells look necrotic. So atypical ductal hyperplasia is clearly the borderline between benign fibrocystic disease and intraductal carcinoma. And in other words, and here's a lobule now, okay? And you remember even in the lobule, the acini had lumens? Well, here, look, the acini don't have lumens here. They're completely filled up with cells. So that's called atypical hyperplasia of the lobule. When these cells are completely filled up and perhaps even merge on one another, then you could call that infiltrating lobular carcinoma. So here's ductal carcinoma in situ. You have all these ducts and there's necrotic junk in the middle. Remember we said necrosis is the number one worrisome feature that makes a duct malignant. But also notice these little ducts are still well defined. They don't stream off into the stroma. And in addition, on x-ray, you might see these little, what they call stippled clusters of calcification. Okay, because these necrotic centers can very easily and usually do calcify. So this represents an extreme worrisome situation for intraductal carcinoma. Here is something that we call Swiss cheese hyperplasia again. And can I also convince you that maybe some of these cells look like they have necrotic junk in them, or they are necrotic? This is also ductal carcinoma in situ. And here's another one when some of the cells look necrotic as well. And in addition, you can see some of the cells here are bigger and smaller and darker, have the usual features of pleomorphism and hyperchromasia. Now, if you want to argue with me what is the difference between DCIS, or ductal carcinoma in situ, and just atypical hyperplasia? We could be here all day and nobody will win. So let's just say there are certain borderline areas where you could either call it benign or you could either call it malignant. But if you call it benign, she may lose a life. If you call it malignant, she may lose a breast. That's basically what we're dealing with here, isn't it? What do we have here now? Oh, we have some more ductal carcinoma in situ. But in this case, you do see that the nuclei have features of malignancy. They're big, they're dark, they're lumpy. There's one in mitosis. There's some with multiple nucleoli. So these are the usual cytologic features of malignant cells. In this one, you can see there's junk inside of some of these little ducts. But do you see how some of these little clusters, areas are very, very dark? That's calcium, okay? It might actually chip off. So what they call microcalcifications with necrosis within ducts, that's very, very, very typical and ominous, and you might even say diagnostic of ductal carcinoma in situ. Here is a specimen obtained from a breast biopsy, and the pathologist put it in the x-ray machine. Our machine we called a faxitron, but they have other names. And do you see these tiny little clustered microcalcifications in one tiny part of the biopsy? This is something the radiologist would pick up right away on a live mammogram rather than in a specimen from a biopsy. Well, these are the things that are most likely to represent intraductal carcinoma of the duct, or DCIS. In fact, it's not impossible that there may even be some infiltration associated with this as well. Okay. This is a Roman bridge. You know, when the Romans conquered places, they often built bridges over streams and that. And do you see how these epithelial cells here of the bridge completely cross the edge of the duct? Okay. When you see a Roman bridge, and I'm going to show you a real one now from histology. Actually, this is a Roman bridge, but actually I think I took a picture of this from China. Okay, or maybe, when I went to China a few years ago, there were a lot of Roman bridges. I didn't know that the Romans conquered China, so maybe the Chinese made these themselves, and we should call these Chinese bridges. Here is a duct, but look, you have a complete set of 100% epithelial cells forming these little bridges. That's typical of DCIS. It's at least atypical hyperplasia, but some people might just say it's a diagnostic feature of ductal carcinoma in situ. Here's a normal lobule. Do you see here's a lobule, here's a lobule, maybe this is part of a bigger lobule, here's a lobule, 1, 2, 3, 4, maybe 5 or 6 lobules, even one up here in the northeast. Well, what happens if those lobules are completely filled with epithelial cells with no lumen? And that's what you would probably call lobular carcinoma in situ. And that's exactly what it is, okay? There it is before I put the label on it, and there it is after I put the label on it. Now, let's talk about lobular carcinoma in situ, because we talked about ductal carcinoma in situ. Now let's talk about lobular carcinoma in situ. I guess you could say with this disease, you could say there's the good news and there's the bad news. The good news is that when you see lobular carcinoma in situ, as a rule, it could be there for many, many, many years before it infiltrates. That's the good news. The bad news is that once it does infiltrate, it has a worse prognosis and it grows faster and metastasizes earlier than ductal carcinoma in situ. So, like that saying, there's the good news and the bad news. Good news, in fact, you want to know something? Many, many times when I've diagnosed lobular carcinoma in situ, you want to know what the surgeon did? Nothing. Even though the word carcinoma was on the report, they say, well, it's probably best not to do a mastectomy. Let's just follow it up with mammograms. So that's the good news, because as a rule, it doesn't infiltrate quickly or earlier, but when it does, it's worse than ductal carcinoma in situ. So here are the risk factors. Of course, older women get breast carcinoma. Women that have had an early menarche, okay, in other words, early puberty, they're more at risk because they have a longer exposure to estrogens. The younger they are when they have a baby, that's a risk factor. They have relatives with breast cancer, of course, that's a breast cancer. Even though there's a variety of genes that have been linked with breast cancer, overall, if you got a closer relative that has breast cancer, your chances are increased too. People with multiple breast biopsies, that doesn't mean the biopsy causes the cancer, but if there's multiple biopsies, it means that something is going on, and the likelihood statistically is of eventually having a cancer. The biopsy itself does not increase the risk. Caucasians are higher in risk than blacks or Asians, okay, statistically. If a person has an early menarche or a prolonged menopause, that means during her lifetime she's been more exposed to estrogens. And does a long-standing effect of estrogens increase the risk? Of course, because estrogen is a promoter. It's not a carcinogen, but if there is a carcinogen, it's a promoter, which means you need both a carcinogen or an initiator as well as a promoter or hyperplastic agent like estrogen in order to cause the cancer. Radiation is known to cause cancers of everything, and breast is no exception. Woman had cancer in one breast, her chance of it having the other breast has increased, of course, because whatever those influences were in one breast, they're still there in the other breast, even if she has a mastectomy. Geographically, there's parts of the world that are higher than the others. Don't ask me which is the worst. High-fat diets are a risk, just like high-fat diets are also a risk for prostate cancer, okay? Obesity, maybe that's related to the high fat, okay? People that don't exercise very much get increased risk factors of cancers and osteoporosis and just about everything, and that should one go without saying. If you do not breastfeed your kid, that's a risk. If you if you lack of a prior pregnancy is a risk. The more babies you have, the less at risk you are. The usual environmental toxins that we talked about that are carcinogenic to everything. Of course, tobacco is at the top of the list. And I put this thing in red. We call it the ABC connection. In other words, is breast factor related to multiple early, spontaneous, or elective abortions? And the facts are, yes, absolutely. Why the government suppresses this data, I don't know. Maybe they don't want anybody to stop their widespread abortion program. And I'm not an anti-abortionist. I'm just telling you, multiple abortions are linked to breast cancer. Of course, staging of the tumor, which is a measure of its biologic behavior, is the most important prognostic feature. And the general rule is, if you do a careful examination of all the lymph nodes and they're all negative, that woman, you could say, has an extremely highly likelihood of being cured, okay? Older they are, the worse it is. Some of the cancers, especially if they appear in younger women, can behave badly, but generally old age is a bad prognostic factor. Okay, your general health, of course, and immunity. The histologic degree of differentiation or grading is a prognostic factor. If the tumor is hard to diagnose, which means it's going to be low grade because it looks like normal breast tissue. That's better than a tumor that is easy to diagnose because it looks like all hell, okay? If the woman has the tumor cells that are estrogen, progesterone positive or responsive, that means she's going to respond to anti-estrogen therapy, okay? There are a wide variety of genetic factors. HER2, also called HER2/neu, is a big one because if certain of those markers are positive, the prognosis is worse. So HER2/neu, ERA, PRA, grading, general health, age, careful examination of the lymph nodes are all basically life and death decisions. And if you wonder why a pathologist might spend an hour carefully dissecting lymph nodes, maybe you think that's as boring as hell, and it is, but it also might result in the surgeon telling the patient that she's going to live. And how do you like that? And then the patient's going to cry, she's going to hug the surgeon, and the surgeon will never tell her that the pathologist did all the work. And that's why we're in pathology, because we don't like to play God. Okay, here's the general biologic behavior. As we know, it starts out atypical, then in situ, then it could early disrupt the basement membrane of the duct. It could infiltrate into the stroma or connective tissue. It then eventually might wind up in the lymphatic vessels and then to the various lymph nodes. Now, if there is one lymph node in the region of the tumor that is most likely to pick up the metastasis first, that's called a sentinel lymph node. And if you only do a sentinel lymph node, you could identify it with nuclear dyes or with regular dyes or isotopes. If you carefully determine what the sentinel lymph node is, then you don't have to take out all the rest of them and possibly disfigure her with lymphedema. And that's often done as a general rule now, more and more and more sentinel lymph node examinations rather than widespread gouging out of all the axillary nodes. The more lymph nodes, the worse the prognosis. If it involves the dermal lymphatics, remember, plugging up those little vessels, we might say the whole breast will become puckered and red, and we call that inflammatory carcinoma. And it's very rare to survive an inflammatory carcinoma. I was sued once because I diagnosed an inflammatory carcinoma, but I didn't say that the margins were free or the margins were not free, because it doesn't matter. And they wound up suing me because I didn't say whether the margins were involved or not. Well, it doesn't matter whether the margins were involved. You don't survive inflammatory carcinomas, okay? And of course, lung, liver, bone, brain everywhere. Now, I want to tell you a special tip about bone. A woman who comes in with metastases in the bone and you don't know where it came from is most likely going to be breast. If she was a man, it would most likely be from the prostate. So here's the rule. Mysterious or undetermined bone metastases in a woman is probably a breast carcinoma primary until proven otherwise. Here's some statistics. You can see most of the, at the time of diagnosis, most of the cancers are already infiltrating. Of course, the more careful you do and the more widespread the mammography programs are, the more likely you are to pick up cancers early, like the in situ stage. And of course, if every woman in this world had mammograms regularly, like they should, or if they could, then this percentage would be much higher. Otherwise, most of them are infiltrating. The infiltrating ones are generally called infiltrating ductal carcinomas or infiltrating lobular carcinomas. There's a couple of variants which have a slightly different prognosis. One of them called tubular, one of them called colloid, one of them called medullary, where they might have a better prognosis than average. So they might add this to notify this doctor, the surgeon, and the patient. Yeah, they have infiltrating cancer, but overall it'll be a better prognosis than not. Could you have a malignant papilla? Of course you could. Could you have a squamous carcinoma of the breast? Yeah, you can. And I know I just told you that almost all carcinomas of the breast are adenocarcinomas, but you could have a squamous carcinoma, but that would be from epithelium that has already become benign metaplastic due to ductal disease. So when those squamous cells become malignant, you could have what they call a metaplastic or a squamous metaplastic carcinomas, which is a squamous cell carcinoma. Let's look at a couple of the better breast cancers, and we'll tell you why they're called tubular or why they're called mucinous. Well, you probably already know why, because there's a lot of mucin in them. Or why they're called medullary. So tubulars are hard to diagnose because they look like sclerosing adenosis, but technically they've invaded. So you might need, for example, a special stain or electron microscopy to certify something as a tubular carcinoma. They're probably the most often types of cancer that are missed. That's the bad news. The good news is tubular carcinomas behave a lot better than any other infiltrating carcinoma, okay? If you have a mucinous carcinoma, it's also called a colloid carcinoma, usually in older women. They have a lot of mucin in it. The medullary carcinomas are infiltrating carcinomas, but they have a lot of lymphocytes surrounding them. Maybe even the majority of the cells are lymphocytes. However, isn't that logical? Because the more lymphocytes you see with the cancer, that means the more of an immune reaction there is to the cancer. So everything else being equal, cancers surrounded by a lot of lymphocytes do better than cancers that are not associated with a lot of lymphocytes. Here's a regular old infiltrating ductal carcinoma. Look how irregular. Look how it's evoking some fibrous tissue response. You might say, well, is that invading the fibrous tissue or is it evoking a fibrous response? Well, it's both, okay? And that's why they're called serous carcinomas. Here's an infiltrating lobular carcinoma. And you notice how a lot of these cells infiltrate linearly? That's called the Indian file, because when the Indians in America used to have war parties, like along a river or, in the United States, they often had their war parties march one right in front of the other. That's why they called it an Indian file. Here we got some British-looking soldiers also having an Indian file pattern. So once again, I think the word Indian file came from America, but it could have been from Britain. I think these Britain soldiers were in India here. Who knows? Thought I'd throw in the picture. Here's a tubular carcinoma. Hard to diagnose. You might not want to call it malignant, but if you notice, these cells are not associated with myoepithelial cells, and on electron microscopy there's no basement membrane. It's just a gland within fibrous tissue. Here are some clusters of glandular cells surrounded with an abundant amount of mucin. Some of them look glandular, some of them look just like clusters of cells. This is a colloid carcinoma. This is also better prognosis than average. Just like the tubular carcinoma is better than average. And here's a medullary carcinoma. And look, practically all these cells on the top here are lymphocytes. And here's a lot of lymphocytes in the middle of the field. And then you got a cluster of malignant-looking glandular cells here and also in the northeast. It's called medullary. It has a lot of lymphocytes. And that's why it's probably statistically, prognostically, probably better than average. I got a couple more pictures here. Could you have a tumor of the stroma, which of course is more resistant to cancer in general than epithelium? And yeah, you can. There's a tumor that used to be called cystosarcoma phalloides. So right away you're going to think it's malignant because it has the word sarcoma in it. But now they just call it a phalloides tumor because they're benign. And it, like a fibroadenoma, it has a lot of fibrous tissue in it, and it's not a sarcoma. Now, can you have a primary sarcoma of the breast? You can. You want to ask me how many I've seen in my long life? To tell you the truth, I don't think I ever saw one. So they're very, very rare. Here is a fibroadenoma, and I should have said more about it because the fibroadenoma, as you can see here, is extremely well delineated by this black line somebody drew from the surrounding breast tissue. Here's lobules here, and here's a big tumor, and it's mostly fibrous tissue, but these little blue streaks are the epithelium. So the fibro is the pink fibrous tissue, which is the predominant feature. So it's a tumor of the stroma or of the connective tissue. And the adenoma is a tumor of, the glands. That's why it's called fibroadenoma. And it is without a doubt, remember this, the most common tumor of young women. It's not cystic, is it? And can I tell you another thing? I don't know if you people have ever played or bounced a super ball, but the super balls are very, very rubbery and they're very, very well defined. And every time I've ever had a super ball in my hand, I bounced it on the floor just to see how nice it bounces. Well, these things bounce almost exactly like super balls. You'll never see that in a pathology textbook, but I could tell you, if you talk to a pathologist, you say, hey, did you ever bounce a fibroadenoma off the floor? He'll probably admit it if he's being honest with you. So they're very, very well defined and bouncy because they have all this rubbery connective tissue. We've ignored men, so I got two little last words to say about the male breast. The primary tumor, or you want to call it proliferation in the male breast, is something called gynecomastia. Okay? Gyneco meaning woman and breast, but it's in the male. If you looked at the differential diagnosis of gynecomastia, some people said, oh, it was related to marijuana and a whole bunch of other drugs, including things like common drug like digitalis. But no matter what it's related to, most of them are related to somehow an increased production of estrogen. So estrogen has an effect of the male breast very, very similar to what it does to the female breast. It proliferates it. Now, does that mean gynecomastia by itself is pre-malignant? No, it doesn't. 99% of the guys with gynecomastia never get breast cancer. In fact, I'll give you another 1% statistic. If you work in a pathology lab and you get 100 breast carcinomas during a year or your life or whatever, 99% of them will be women and only 1% will be men. So yes, there is something called carcinoma of the male breast. I've seen a couple cases. They're very, very rare. Now, here's gynecomastia. And you could say, hey, maybe this is a lobule. Well, guess what? It's basically just ducts that kind of end bluntly. They don't develop into a full-blown lobule, even though the breasts may be bigger than usual. And that's, of course, a estrogen effect. But the estrogen effect in itself does not cause full lobulation of the male breast lobule. You know what? I'm happy because I think we did a good job. And guess what? I'm happy because we are in PowerPoint number 447, which means we did 9 webinars on the genitourinary system, and this is the last webinar of the last topic. I think when we do the next webinar, which will be next week, well, maybe we'll do a lab, or maybe we'll just do a dance or something like that. But we are finished, and how about if we close the PowerPoint now? And it's still not quite the full 2 hours, even though we had a whole bunch of PowerPoints. And how about if we play our last song? And I think that our last song is also going to be my favorite Phil Collins Genesis song called In the Air Tonight. It has a very eerie effect. I think you'll love it. 22.